and yeah, I like. Okay, I will just like want to. So you all saw me, see me now, and you will just hear my voice from now on. Okay, thanks very much for letting me talk here. I'm really excited about that. Okay, I'm sorry. I will just okay, I will leave it with my mobile phone, and I can leave. Yes, and I can continue. Do you see? So,
Yes, that's perfect. Thank you.
okay. Now you see my screen and you see my mouse moving and everything's fine. Okay.
Yes.
Thank you. So if you have any questions, you definitely can put them in the chat. We can discuss it in the end. I really hope that we can if there is any problem during the presentation, something is like technically wrong or something, just jump in and tell me. It would be great. So I would like to tell you something about describing chest X-rays, which is actually I think the hardest thing in the radiology, and it's definitely hardest thing for the medical students to grasp when they are studying X-rays. I will divide the lecture into actually two parts. I hope there will be time for the second part. If there will be less time that we would like, we can sometimes, if there will be, if you want, we can continue with any time after that. So I will start with some ways how to grasp describing chest X-rays. So what to look for, and some kind of ground rules and some to-do list, what to do and what to look for. And in the end, I have some I have some X-rays prepared for you, and we can go through the X-rays. If there is anyone who actually wants to describe it and jump in and describe it the way I told you, I'm going to tell you, that would be great, and we can discuss it. I have no idea how long it would take me to take you through all that. We will see. Anyway, so let's start with the X-ray image. When we have X-ray image, there are a lot of things we need to do. Usually, students have some like kind of idea that well, I have a picture and I need to tell the diagnosis right away. Okay, like this X-ray, oh, that's tumor, that's pneumonia, and so on. And that's not how it works, actually. We usually don't tell the diagnosis from X-rays, which is probably a new idea for most of you. We usually say what's there. We just describe the picture. Radiology is descriptive thing, and we just like tell that this is this and this is this, and when then we are discussing what differential diagnosis or what diagnosis this can be. So whenever I see an X-ray, I always start with the name of the patient, date of examination. This is really important because sometimes you open old examination and that's not nice. And good thing is when you are actually the second thing actually is that we look for prior investigations, like prior X-rays. Usually the patients have more X-rays than this one, so even if the patient came with something new, like some okay, he has some problems now and we do X-rays because of that, we usually check for older X-rays because there can be some things that changed due to time, and it definitely changes our differential diagnosis. Some things can get bigger, smaller, and so on. So always look for prior X-rays that we can use to compare that. The third thing, and that's actually something I won't talk much about these two things because that's a practical thing when you're working in a hospital. But the third thing is actually something that we will start with, and that's technical quality of the picture. Always, and that's not just with chest X-rays, with any X-ray, always look for it look on technical quality. That means if you have bone X-ray, it's how it's if it's not rotated, if the projection is fine, and so on. If there is actually the size of the part of the body you want to see, and so on. On chest X-ray, it's really important. I will show you how technical quality can like show us different things that we don't want to see. Then we look on the image. There are actually two main ways how to look for that. Random search means that I will just like look on the picture and let my eyes wander. This is great. This is definitely something you should do, but you need experience for that. Like to find something with the random search is things that works with radiologists. When we see like really hundreds of chest X-rays, it's usually when I see the picture, well, my eyes usually turns to some spot where something is out of place for me. But that really needs, you need to have the memory, like the shapes of the chest X-ray and the chest in your head. Not that you usually, definitely you do that also, but you usually miss the pathology for the first sight, and then it's not a bad thing actually, because we have systematical scans and we will check the X-ray in some way that I will show you. Always do the systematical scan also. Radiologists sometimes have problems to do that because they just think that they are so good that they will find everything from the first sight, which is not true. Always systematical scan should be always there. When we find something that is pathological, and that's actually a really big sentence that I told right now, because to tell that something is pathological, that's actually the most important thing on any X-ray, because to recognize pathology and to recognize something that is not normal, this is the most like the hardest thing you have on X-rays. The good thing with medical students, when they are examined, usually get pathological pictures. When I give a student a physiological picture, that's the worst thing I can do. But when you are in praxis, you need to know what is normal, which is actually the main thing that anyway. So when you find a pathology, so something is out of place, we usually localize it, and that's actually a problem. Sometimes it can be anywhere. It can be a chest wall, skin, for example, or lung, or somewhere. So we try to locate it. There are some ways how to locate it. I will show you some of them due time. And then there is actually a good thing when you find a pathology, you try to categorize it into these four categories I will give you now, and then we just describe it. We describe the pathology. That means something is too white, something is so. We divide the pathology into four things. It's either too white or too black, and that's actually really hard, because white things usually if you have something in the lungs, it's usually whiter. Fluid, tumor, inflammation, atelectasis, and it means there is more air. So that means it's either pneumothorax or emphysema or some air trapping or something like that. And used to shades of white or shades of gray, then shades of black. So something is bigger or smaller, usually bigger. And wrong place is really like dynamic in volume. If you have atelectasis of some part, chest X-rays are usually in default setting when you need to do chest X-ray, and the patient can stand up and go to the radiology department. We usually do it standing up in posterior anterior projection, on PA than AP, because heart is actually right neck behind sternum, and we try to press the heart as close to the film or to the detectors as possible, as far from the X-ray tube as possible. So that's why we do it posterior anterior. That's in default setting. You see the difference between AP and PA. The heart is bigger in AP because it's much closer to the X-ray tube and it leaves bigger shadow. And the lungs are not that nice. That's the reason why we do that. PA. If it's not in this default setting, it should be mentioned on the picture. So usually it's some, you see there's erect picture. Sometimes they actually wrote down it's standing. Sometimes it's written it's supine or lying down or bedside or something like that. So that's projection. Much more important thing is the position of the patient. So standing up or lying down, because fluidothorax, for example, or fluid or effusion, it changes shape when you change the position of the patient. pneumothorax also. Anyway, the main three things you need to grasp is inspiration, definitely. So you look on the diaphragm. You can count the ribs. I don't want to go much into that. There is a really easy rule. The heart should lie on diaphragm. If the left dome of diaphragm is behind, covering the heart, like here, you see the heart is like behind the diaphragm. It means there is insufficient inspiration. Why is it important? It's we usually don't like redo the picture because of that, but when you have inspiration, there can be a lot of shadows in here in the lower lung zones, which can be due to the compression of the lungs, because there's just too much lung here and it's whiter. So whenever you have inspirated picture, you need to be careful about saying anything wrong in the lower lung zones. Rotation is the second really important thing. We usually check, this is a rotated picture, there is a scoliosis, really big scoliosis, and we usually check the clavicles and spinal processes. And the spinal process should be in the middle of clavicles. That means because this is on the end of the body and this is in the front, it means it's not rotated. The rotation usually changes, it can change lung hyla. Lung hilum, you can see there is no lung hilum here because they're just like covered because it's rotated. And it can change the whole transparency of the lungs. The lungs can get just whiter. One lung can get, the whole lung can get whiter just because there is a rotation. It's actually one of the most common cause of if you have the whole hemithorax whiter, it's usually because of rotation. So when you have problems with whiter hemithorax, just look for rotation. And penetration is the third thing. It means like exposition of the picture. This is even if it's slightly rotated, it's nicely penetrated picture. It means you should see vertebrae like spine in the mediastinum. You can't see it here. You can see it here, but that's the second. That's the border, the other border. So you should see the spine, and you should also see lung markings behind heart and diaphragm. You see the vessels here. See the vessels. This is underexposed picture. You see that it's too white. You can't see anything in the lung in the mediastinum, and this is overexposed. This is underexposed. Oh, bad exposition anyway. I always mix that. This is nice picture. You should see stuff in the mediastinum. Okay, so that's it. I don't know. Is there any way to see if there are any questions so far? I would definitely want, if you have questions, we can do some pause and we can talk about that, because I think there can be questions about this stuff.
There aren't any questions in the chat yet, but everybody feel free to put them in there if you'd like.
Okay, just if anyone have questions, you can jump in now or put it into chat. If there is no, we can continue. Great. Yeah, okay, technical quality, now we have it. Okay, and that's and this is, I think, I'm sorry for the small text. I will go through that and you will see it in bigger letters in a minute. That's just what all the things we are going to go through while we are going to check the chest X-ray. And this is actually what we start with. You look on the chest X-ray, you see if it's technically right, and or just assess the technical quality, and then we are going to go through these things. This order of things is just something that I made up for the lecture. If you look in different books, different like lectures, different authors, they use different order of things. Usually books start with bones, which I put on the end actually, because bones are usually something that you missed. So that's let's start with that. But I have this order because it seems kind of a, well, I like it this way. It's totally not important in which order you are going to check the things. Most important thing is to check everything. So if you have some kind of a, because you usually have some letters for that, A, B, C, D or something. I'm kind of not using that, but you can find a lot of things online for that. But this is how I'm going to go through that today. So lung fields, that's like this. We are not talking about lungs on chest X-ray. We are using lung fields and lung zones because lung field and lung zones contains not just lungs, but it contains also like all the soft tissues in front of the lungs, on the back and on anteriorly, and all the muscles also, pleura, ribs, everything. So if you have some shadows in here, it can be anywhere. It's not necessarily in the lungs. That's why we are not using lungs. We are using lung fields and lung zones. I hope that's clear. Lung hyla, that's this area here, hilum. Oops. Heart. There is one problem in sometimes in anatomy you're learning and you're studying that this is the heart shadow is everything in here. For our sake, heart is just this lower part. It's just the right and left heart. The upper part we can call mediastinum because well, everything is mediastinum actually, but we will talk about mediastinum in here. And then diaphragm, and then bones and soft tissues. I will tell you why the bones, I put bones on the end, and soft tissues, that means tissues around that. You can see it here.
Sorry,
okay.
we've just got a couple of questions in the chat.
Definitely, yes.
If the projection isn't labeled, how can you tell if it's PA or AP? And like, how would you go about determining this?
Great. Yes. Okay. If it's not labeled, if there is nothing written, I suppose it's default and it's PA standing. This is default setting that don't need to be mentioned. Any other things should be mentioned and must be mentioned actually. That's how it works. If you there are some rules for distinguishing APPA standing and lying down. All of them are inconclusive. If you have two pictures next to each other, one is AP and one is PA, I can tell you which is which. But if you're just one, you actually can't tell. There is some things like the ribs that are closer to you should be like sharper than the ribs that are farther, but this is not working, trust me. There is one thing that can tell you that the patient is standing up, and that's air fluid levels. If you have air fluid levels, for example, in the stomach, this definitely that can tell you, okay, this patient is standing up. And like the radiological technicians would be really dumb if he do AP picture standing up, because that's not how it works. So there are just things like that, but there are actually all the things that you can like read in the books are just like non-conclusive, like scapulas and so on. Just in the hospital it works like if it's like nothing is written on that, just L or R, R or L, it's standing up posterior anterior. If it's otherwise, it must be mentioned on the picture that it's PA or it's lying down. Okay. Any other questions? If there are none, great, thanks. We can continue. Great. So now I will go through all the things and tell you what's important there. So let's start. That's the things we are going to go through. So let's start with lung fields. That's actually something that you mostly when you imagine examining chest X-ray, that's the thing you think that is all about. So we start with the whole lungs. We start with the symmetrical the transparency of the whole lungs. They should be symmetrically transparent. You see here that this hemithorax, the left hemithorax, is whiter than in here, which is actually because there is a breast here and there is no breast here. So that's one of the reasons for that, but there can be a lot of reasons that I put it. This is mastectomy picture, just kind of a typical picture when you want to show somehow there is a difference in transparencies of hemithoraxes, but that's the lungs are normal. It's just to show you how the breast can do whiter lung here. It's really hard, nice to try to find horizontal fissure, which should be somewhere here. And if there is no fissure like here, that doesn't mean anything. It's either not there because the fissure can be like like not made at all, but it's usually because it's not in the same direction as X-ray beam. That means it's not visible. It's usually there, it's just not visible. But if you have it there, it's nice because it tells you that everything is in order in the right lung. Everything is order like in volumes. It means there is no atelectasis, no shifts, nothing major going on in the right lung. So horizontal fissure, it's a great thing to start with, and the symmetry, asymmetry. Sizes, and then check for opacities, shadows, and translucency. This is actually a thing that is the most important and most terrible thing to do on chest X-ray. There can be a lot of shadows like diffuse shadows, or just lesion, tumors, and so on. Usually you describe it as describe it as alveolar or interstitial. Alveolar is much more like hazy, like clouds. Well, you see there are a lot of clouds. There is a there was one nice April day. I was on a date, and everything I did was that I saw the clouds, and I was taking pictures of the clouds because my radiological soul was really excited for that. You see, it's like that. This is alveolar. That means it's like a hazy thing. It's like small clouds like that. If it's more linear like that, more lines, it should be interstitial. The problem is that the processes are usually both interstitial and alveolar, so it's usually like that, and you just can't say much. Also, this distinction was important when there was no HRCT. When we have HRCT, which we can tell really a lot of things about lung parenchyma and what's going on there, which can be actually for a lot of other lectures. So we usually just say that there are just opacities, and sometimes it's hard to distinguish that interstitial. If you have interstitial processes, this is usually in cardiac edema, for example. It's really nicely seen that you have a lot of lines there, but trust me, you need a lot of experience to distinguish these things. We can talk about it later, but I don't want to get mixed much into this now. So that lung fields, we'll work with that. Lung hyla, we should find the hilum on the left side and right side. The left one should be higher. They can be on the same level. Right side should not be up higher than the left one. This usually means that there are some shifts. Some atelectasis can do some shifts of the hilum and so on. Some tumors can do that. If you actually don't see the tumor, it can just be there and do the retraction only. And so it's actually good to look where the hilum is. And the size is actually important, but not just size, but shape and transparency. Shape means they should be concave like this, because this is made by vessels. If it's not concave, it's
Dr. Benish, I think you're muted.
Yeah, the host muted me, was written there. I'm sorry.
Oh,
yeah.
sorry.
No, that's fine. Okay, yeah, now you hear me fine. Okay, so they should be concave. If they are concave, it means that even if the hilum is really big, and it is still concave, it means it's usually because of the vessels enlargement. Because what is in lung hilum? Vessels bronchi, which usually we don't see much bronchi here, and lymph nodes. And that's the three things that can make problems here. So usually vessels or lymph nodes are the things to look for. So if it's concave, it's fine. It's usually vessels. They should be symmetrical. And what is the important? The transparency is important, and also symmetry and transparency. You see, in this lung, that you have hilum somewhere here, and the left hilum is much brighter, and it's actually not supposed to be bright as this. It should be transparent. It should be somewhere in between lung and the mediastinum. This lung hilum is white as the mediastinum. This is actually, I think, lymphadenopathy. There are lymph nodes in here, which is not much like, it's not enlarged much, because that's a vessel usually, but it's big. Just because it's whiter, it can be a problem. Actually, lung hilums are one of the really missed places on chest X-ray when you look for some tumors. They can be hidden there. There are a lot of lungs in front of the lung hilum and behind lung hilum. So don't underestimate these areas. You can see this is really big lung hilums because of the lymph nodes. In this case, it was sarcoidosis, but this can be lymphoma. This can be well, silicosis, sarcoidosis, lymphoma, actually tumor, and that's mostly everything I can come up with. On this picture, again, you see big lung hyla, but in this case, it's probably because of the congestion, because there are vessels in there. But you can see this is really similar. You would need a picture in bigger size to distinguish this. This is like more round, and this is more like linear, but sometimes it's really hard to distinguish these things. You need also some history of the patient. You need some dynamic of the process, and so on. So it's just big lung hyla. There are just few things that can cause that. So lymphadenopathy from any causes. Don't underestimate sarcoidosis. It's quite common thing. Lymphoma, definitely, tumors, but also just the reaction. If you have inflammation, there can be bigger lymph nodes, or vessels. Usually vessels are enlarged in arterial hypertension or pulmonary hypertension or the congestion. Okay, then heart. Be careful about heart. Size of the heart is not important, and like I can sign this statement anytime you want, because when you check radiological textbooks, there are a lot of ways how to distinguish valve problems, like our aortic valve stenosis and so on chest X-ray, how the shape of the heart is different in this valve pathology and so on. That's not a thing we are usually diagnosing now these days, and it's definitely non-leg artist actually to diagnose heart pathologies from chest X-ray. We have echocardiography for all that. So the only thing we tell from chest X-ray is if the heart is enlarged or not. We use something called thoracocardiac index. That means the heart should be can get twice into the size of the chest. If it's bigger than 0.5, this index, it's usually enlarged, but the enlargement is actually not important. And be careful about that on the lying patient pictures, like on the AP pictures, because heart is always bigger on AP pictures. So we usually use that if the heart is not normal and is just slightly bigger, we use like border size of the heart or just a slightly enlarged heart, and it actually doesn't mean anything. It's just there. If the heart is like that, okay, I will say, yeah, there's cardiomegaly. There is definitely big heart, and this is like a really cool case of this person have a dystopia of the heart and have a heart in the abdomen. You can find it online, but this is missing heart. This is a really small heart, but no, it was just mostly for a joke. Smaller heart is usually not a problem. It's more usually a bigger heart. Be careful anyway. Be careful about changes in the heart shape due time. It means if you have a patient with heart like this, and you have previous X-ray, for example, 1 year ago or half a year ago, and the heart was like this, it's usually not because of the heart enlargement. It can be due to pericardial enlargement. And pericardial thing is really important to diagnose. You usually can't say from, well, there's, again, in the textbooks, they will tell you how to distinguish pericardial effusion, like it's like a bag of fluid or something. This actually can be pericardial thing, definitely, but it's, again, it's not 100%. You can't like count on that. But if you have positive dynamic in the heart size in small time, it can be due to pericardial effusion. Be careful about that. And what I want really to emphasize here and to tell you, much more important thing is that in the heart shadow, there is a part of lungs hidden behind heart shadow. And if, as I told you, if you have X-ray which is the exposition is fine and as well penetrated, you should see the lung behind the heart. And on this memo, actually, you can see that there is a heart and there is something in the heart shadow. And there is actually, I think this was a tumor, because I remember this case from some website, but this actually can be anything from skin lesion to something on in the muscles. But you should see that, you should look for that, and be careful about things in the heart shadow. It's much more important to look for things in the heart shadow than to tell something about how big the heart is and what shape it is. Okay. Fourth thing is mediastinum. So we will check the upper part of the mediastinum. There are actually two main things that you should look for, and that's size of the mediastinum. So if it's enlarged or not. It's usually enlarged because of some mass in the mediastinum. Like here, it should not be here. This thing is probably lymph nodes. It can be a lot of things, but there is just some enlargement of mediastinum, and there is definitely large mediastinal mass here. And then a border. That means a silhouette. Silhouette sign is a really important thing. That means silhouette sign means that you have silhouette somewhere, you have a border somewhere, and the border is made by different translucencies. That means I see the mediastinal border because the mediastinum is surrounded by aerated lung. If the lung adjacent to the mediastinum stops to be aerated, like here, you stop to see the border, which is called silhouette sign. So we are searching for the borders. If you can't see the border, it means there is something wrong with the lung adjacent to the mediastinum. If this would be somewhere in the back, or for example, on the chest wall, or some other things, you would see the border of the mediastinum. We can tell from this picture that this is something in the lungs adjacent to mediastinum. That means in the lung, in the upper lobe, or something, or whatever it is. So that's the two main things. So size of the mediastinum and border. This is in the be careful in children. This is small child, and you can have thymus like this. This is called sale sign. You can have it in the small children because they have really big thymus. So that's mediastinum. Then diaphragm. Diaphragm. Well, you usually check if the right dome, how high the diaphragm is. The right dome should be higher, or can be higher, and be careful here. The difference. The normal, it can be really normal to have it on the same size, and the left can be sometimes higher, and it's still normal. Different, again, important thing is changes due time. So if you have patient like this, and after a year the left lobe, left dome would be higher, there can be something wrong there. Like here is elevated. You should check for air. below a diaphragm. So this is pneumoperitoneum in here. Uh, it's just like usually obvious when you look for diaphragm that there is something wrong here. And check costophrenic angles. So that's this part here. And be careful about that, because usually students you can see how if usually students when start with chest X-ray, they start, okay, heart is not enlarged and costophrenic angles are fine, because that's actually, well, heart, they know a heart from anatomy, so they want to sell it, and like costophrenic angles, that's the only thing that have different name that you should like study and you should remember. Costophrenic angles are these areas, and yes, they should be sharp like that. But they can also be hazy. There can be some problems with here, which is not just fluid, but okay, yeah, there can be fluid here. And you can see here that this is on the side picture, the lower part of the pleural cavity is somewhere in here, and you need at least half a liter of effusion to see something in the lateral costophrenic angle like that. You can see it on the lateral projection, which you usually don't, well, it should be made, but it's not that often these days. But there can be a lot of fluid without and lateral costophrenic angle can be normal. But there is one more thing. If you have a patient which is lying down, the lateral costophrenic angles like loses its importance now. Well, because, well, not that obviously, because like patient, when you have lying down patient, the patient is usually not lying down totally horizontally. It's usually the head is a bit higher, so still there can be some problems with the costophrenic angles if you have effusion, but there needs to be a lot of effusion for the costophrenic angles to be visible. So my point here is costophrenic angles are overrated. Just, yeah, look there, but like don't do diagnosis just because you see them. But yes, if there is a problem if there's effusion, it usually starts here. So that's diaphragm. Trachea should be fine. I think I should place trachea next to mediastinum, after mediastinum, because it's in there, and you can see it. And again, you see the picture from mediastinum slide, and you see that there is some expansion here, and you can see the trachea is shifted like that. This is trachea. It's dark in the mediastinum because it's filled with air. It's not always visible. If you can't find trachea, that doesn't mean that the patient don't have trachea. It just means that the picture is not so nice that you can see that. But if you see it, just like look where it is, because sometimes it can be dislocated. It's usually dislocated by aorta a bit, because it's this is aorta here, and sometimes it's going around it a bit, but it's not supposed to be like turn like that. So that's it's actually telling me that this mass here is next to trachea. It can do some kind of information, because it's definitely not something in the posterior mediastinum, for example. This is not a tumor next to spine, because it would dislocate the trachea anteriorly, not like that. So trachea is in here. Just, it's good to look for that. And you see it can be shifted. This is pneumothorax and this tension pneumothorax with shifted mediastinum and trachea. Sometimes trachea is the only thing you can find in mediastinum. So trachea and bones and soft tissues. Why did I put bones on the end? The problem here is that when you want to diagnose something on in the bones, like traumatology or like rib fractures, you should do totally different X-ray. If you do chest X-ray, like classical chest X-ray, it is made for lungs, heart, and like congestion and heart things and mediastinum, not because of the ribs. If you want to see ribs, you would do the X-ray totally different ways. You definitely need to look for the bones or check the bones, because there can be some problems there. Like, for example, here you see that there are like older fractures of the ribs. There's defiguration of the ribs, which is because there was some older fractures. And if you just don't know that, you can see that, you can think that there can be some tumors in the lungs, it can get really messed up. Well, now you see that it's ribs because I told you, but if I don't tell you and showed you just this picture and ask you what's this, some of you can think about some lung things, and there can be a lot of lung things hidden behind that also, but it's mostly be careful about that. So yeah, check the bones, but be careful about that. If you can't find something, that's usually don't find something on the bones. But yeah, don't forget about that. It's just collateral findings usually. And soft tissues, I mean the things around that. That was the thing I showed you previously. That's with the ablation of the lung. So, for example, if one breast is missing, it can do a lot of problems. Always check for subcutaneous emphysema. So if you see dark spots in the soft tissues around that, it means there is air in there. So there's emphysema, which means something is wrong. In here you have a chest drain, so that there was some fluid of air from lungs growing here, or from the drain. It was a pneumothorax probably. But if sometimes you just find emphysema, and it just can show you that there was something wrong. And you can see there is also emphysema in the muscles, between muscles. You can see the pectoral muscle here. So that's a soft tissue. So that's the way. Yeah, it took me 50 minutes to go through that, as I supposed. So we have 10 minutes now. I will go through a normal chest X-ray now, just to tell you all the things we saw today now, and I will go through a few pathological pictures. I would really like if there is any one of you there who want to try to describe it. You can describe some of the pathological pictures. You don't need to follow this list. You can have your own list, but just like don't forget anything. I will show you a normal, nice, healthy chest X-ray. So you can see that when we start, there is actually a slight rotation, because this is clavicle, and spinal process is not in the middle, but inspiration is fine, and penetration is fine. So let's start. Lung fields are normal, symmetrical, no shadows, nothing wrong there. Hylum right is here, slightly lower than the left one, which is nice. They are transparent, they are concave, nice, fine. Heart is not enlarged, which and there are no shadows in the heart shadow. No other shadows. Mediastinum is not dilated. Costophrenic diaphragm is fine. Costophrenic angles are sharp. Trachea is in the middle, slightly deviated around aorta in here, which is normal. And bones, I don't see anything on the bones and on soft tissues. So that's normal chest X-ray. So I will show you a pathological one. And okay, we can start with this one. Is there anyone who wants to try to do this, or do I can do that?
Feel free, anybody, to put your hands up if you want to start, or just unmute.
Great, yes.
In the meantime, we have a question in the chat. How do you manage subcutaneous emphysema?
Manage, well, it's the air in the subcutaneous tissue actually don't do much damage. It's important thing because well, it usually resolves itself in time, but it tells you that something happened there. So it's the reason for like the impact of this finding is mostly diagnostical. But yeah, if it's really big, it can do some problems. But the main thing is not to do it bigger. So you need to resolve the reason for the emphysema, and then just it doesn't matter.
Thank
okay,
you.
You're welcome. Okay, does anyone raise a hand, or should I continue?
I can do it.
Great.
It's better to make a mistake here than in the exam. So, okay.
Great.
So first of all, I will look at the lung fields. No, well, to start from the beginning, the left side is here, the right side is here, PA projection, and then the right lung field is mostly clear. The left one, not so good. The costophrenic angles on the left side doesn't look so good. Not clear. However, the right one is good. They are not exactly symmetrical, the right and left side. The hilum is concave and is looking good. The chest side is, I would say it's normal, mostly normal. The right hemidiaphragm is much higher than the left hemidiaphragm. Did I miss something?
Well, yeah, heart, mediastinum, bones, soft tissues. Okay, yeah. Yeah, great. Thank you very much. So what do you think the main problem here is? Can you sum it up somehow?
So I think that there may be a left side pseudothorax.
Okay.
But
yeah, okay, yeah, great guys. Okay, yeah, thank you very much. So let's go through that. Yeah, thank you. It's really great because I can show I can show some really nice thinking errors you can have, which is normal. It's just totally normal. If you say this to me at exam, I would say, okay, yeah, that's great. You have some of things wrong, but it's totally obvious that you have that. So let's go through that. Yeah, thank you. One thing is that yes, this definitely this lung field is whiter than this one, and there is one problem because sometimes when there is a problem with something which is just darker, and the pathology is darker, usually I think that the darker thing is actually healthy and the whiter is unhealthy. In this case, this is a healthy lung, and that's the problem is on this side. And I can tell you why. If you look on this, and the main thing that actually you told is that the diaphragm is higher. And just imagine when you have a process, because why the diaphragm is higher, it can be because of something happening below the diaphragm or something happening with phrenic nerve. That's the two main causes. There is no tumor in this way, and so there can be something happening in here. And when the diaphragm is higher, what happened with the lung? The lung is compressed, and a compressed lung is usually whiter than the uncompressed lung. So I would suspect that when the diaphragm should be higher, I would suspect this lung to be whiter, not darker. I don't know if you get what I mean, but this is actually a really important thing. This means that there is something wrong here, and the reason for the diaphragm is actually in the lung. In this case, there is a part of the lung missing. This is patient after lobectomy. When you remove one of the lobes of the lung, it looks like that. Truth is that you usually don't need to diagnose this in praxis. You usually know about the history of the patient. You can just ask the patient, did you have lung surgery? And the patient usually knows that. So that's just I want to show you this to see how you need to think when you are looking on chest x-rays or just x-rays in general, because that's how it works. It's darker definitely than here, and I totally get why you think that this is pathological. The problem is that you told pseudothorax, which would be actually pseudothorax can looks like that if the patient would be lying down. It would be in the back. In standing up patient, pseudothorax should be in here, and we actually see the diaphragm here. So even if we can't see the border and the costophrenic angle is not visible, actually, we see the diaphragm. If there would be pseudothorax that would do all this, I can't see diaphragm. That would be just the silhouette sign. There won't be any diaphragm here. So there is probably, well, there can be some fluid, I can't tell, but this whole thing is not pseudothorax. It's just soft tissues in a way, and just much more lungs than in here because there is lung missing. But again, this is not for something that you need to diagnose. You should know that from history of the patient. But this is how you need to think when you're looking on chest X-rays. That's actually the only thing. That everything else was fine. Any questions? Anyone around this, about this picture? We have time for one or two more. Okay. I have
sorry, Manon, you have your hand up. Do you want to unmute?
Hello, yes, I have a question.
Definitely.
Namely, what are those nodular-looking lucencies in the right lung field?
You mean
Further cranial. Yeah, those. Is it normal or pathological?
linear, like this stuff, or this stuff?
The lucencies.
Lucencies, like this, the dark thing here.
Yeah.
That's actually the what you know when you have half of the lung missing, the rest lung needs to expand. So there are a lot of like air in there, and it's usually these areas in the lungs can be darker. You can see it's even darker here, because you have a lot of soft tissues around here. You have pectoral muscle in here, pectoral muscle and axillary folds, and so on. And in this area, you have much less muscles and soft tissues around the thorax. That's why it's usually darker. And when you have really badly penetrated picture, sometimes you have just dark spots in here. So that's areas just because there are less soft tissues. It's totally on the role of the soft tissues. It's really underestimated by all viewers who are not experienced in that. Thanks for the question. I really like to correct everything that is that you think is actually pathological and it's normal, because when you look on the chest X-ray, so well, for 15 years as I do, you just take it as normal, and I'm always surprised by things that you find abnormal, which is great, because I need to know that you find that abnormal to tell you that it's normal. Any other questions?
Thank you very much.
Yeah, you're welcome. Okay, we have another picture. I will do a translation. Vleže means lying down. On this screen, does anyone want to describe that?
I can try to start it if nobody minds. So I will start with the lung fields again. So if we compare the transparency, the right lung field, there's like an opacified hemithorax.
Yes, great.
Yeah, and there is compression, I would say, of the left hemithorax. Because the lung field is smaller than the lung hyla in the right. Well, they're opacified, obviously. In the left, I would say they are concave, and the transparency is a bit.
Yes.
So it's like more opaque. The heart shadow. So the. Well, there's maybe blunting of the left costophrenic angle, and the right is opacified.
Yeah, we can say that, yes.
Yeah. Then the mediastinum, the borders on the right, there's like, they're not as clear as compared to the left. Mediastinal border, so maybe you could call it the silhouette sign.
Yeah, probably here, yes.
Yeah. The diaphragm on the right, I can't really see it.
Great. That's the silhouette sign, definitely.
Yeah, and on the left, I can't really see it either.
Yeah, but that's because of the heart, probably. Yes.
Yeah. The trachea is slightly deviated to the left.
I think it's in the middle.
Okay, it's in the middle.
Great. Yeah.
Bones. I can't see anything looking at it right now. And soft tissues. I wouldn't say anything.
Yeah, great.
Logical either.
Yeah, great. So what do you think about that? What do you think it's the cause for the difference in translucencies?
I would say maybe a severe effusion, like fluted thorax.
Great. Yes. Great. That was really great. Thank you very much. Thank you. Definitely. You can see that how it's whiter. if you're a flying patient, this is the difference between that I can actually tell you that this is not a pneumonia of the lung, because you see the lung markings. It's actually the lung markings are similar to on both sides. Just on this slide, on this side, it's just more hazy. The whole hemithorax is just like covered with something, and that's because there is a fluid behind the lung. You can see this is actually interlobial fissure, which is actually something you should like. Okay, this is on normal position, which is great. And if it's enlarged like this is thickened, that's usual with fluidothoraxis. And again, you see the crescent sign because fluidothorax, because it's around the lung, it usually do the impression that that is much more fluid in this area because it's around. There is a silhouette sign of the diaphragm because there is no difference between diaphragm and lung, because there is no the lung is not reaching diaphragm because there is fluid in between. On the left side, the left lung, I think it's not. You told that it's smaller, the hemithorax. I think it's just because of the big heart here, and I actually think that there's slight rotation, even if this seems not normal, but the lung hilum are not in the position they should be. There's probably some other people. Generally, in lying pictures, there are a lot of problems like that. There's much bigger normal varieties. So definitely fluidothorax, left-sided fluidothorax like that, and the hilums are like not visible much. Great. Any questions?
There's nothing in the chat so far.
Okay, great. Well, I don't know if can we do one more. I can ask my colleague because he's working here instead of me. Tuklet. Okay, well, I think we from my point of view, I can do one or two more if you like.
I actually have one question.
Definitely.
So on the left lung, there is this line, and it looks like the line that we would see on a pneumothorax.
This one. Yeah, great, thank you. That's a really common thing. Can someone tell me what it is? Do someone know what this line is?
The medial border.
Scapular line.
Scapula, yes. Thank you. This is totally normal. Don't be shy. That's a great question. Be careful about scapulas, and definitely in lying down patients, because when you have standing up patient, you see here, scapulas are in here, because if you have patients standing up, they are asked to move their shoulders forward, so the scapulas are moved from the lung fields. Lying patients usually have scapulas in the lung fields, which is one of the things how you can recognize the picture. I just because of that, I would say, oh, this is not much possible for the patient to be lying down, because you usually can't do that while you are lying on your back. But you can have it like this one while standing up. So this is scapulas, and they can do a lot of problems. And anytime you see a line, always follow it. Try to like see it in the bigger picture, and this is just a scapula. Great question, thank you very much, because this is really something I really need. I really would like to for you to see and to look for and be careful about.
Okay, thank you. Also, another thing regarding the heart, you said that you don't really care too much about the size of it,
yes.
But like in this case, it does seem a little bit big, no?
Yes, it is. It's lying patient. It's AP, but it is definitely slightly enlarged. But well, imagine that you are internal medicine doctor, and someone will wrote you there is a enlargement of the heart. What does it tell you? Even if I would like say that there is probably left-sided this heart shape is usual for aortic valve problems or something, still you need to do echocardiography for some diagnosis, and if I tell you just it's enlarged, you need much more information about history and physical examination, and you would definitely do echocardiography. So the information is actually not important. Yeah, it is important to tell, okay, yeah, the heart is definitely not like healthy, the size is enlarged, but it also depends how old this patient is. If this would be 20 or 30-year-old patient, I would say, oh, this is pathological. I will put him on into cardiology and look for the problem. If this patient would be 90, I would say, oh, this is just 90. Oh, this is normal in this age. Okay.
Yeah. Okay. Thank you.
You're welcome. Okay. I think I don't want to do another things. Do you have any questions concerning anything else? I think if you like that, we can actually in some other time we can do it again. I can just do this X-rays and we can go one after another. I can prepare some like typical pictures which we can discuss and do it, because that's actually a thing that you will show you how the diagnosis is done, and it will give you, I think, a lot of things we can I would really like to do that if you would like that, because this is a great opportunity for all of you, I think. If it's fine with you, I will switch to the last two pictures and I will give my word to girls. If you have any questions, you can ask. Are there any other questions in the chat?
There's just lots of people saying they'd love another session and to go through more chest x-rays, and can we have abdominal x-rays later, and CT and MRI. I'm going to put the feedback form in now. The talk's not over, but any more talks you'd like Dr. Benesch to do, if you just add them into the feedback form, then we can schedule them all for coming into April and May. Okay, so any more talks you want, just put them in the feedback form. That would be really great. Thank you.
Yeah, just don't. I don't like MRI much, but I can talk about anything because I really like to listen to myself. So I would be glad to come anytime you are free.
Thank you so much.
Yeah, you're mostly welcome. So I can give. I'm muting my phone, my microphone. Thank you for inviting me. I really enjoyed that. I really like all your insights into that, and I'm looking forward to meeting you next time.
Thank you very much, Dr. Benesch. If everybody could just put in the feedback
Thank
form,
you so
I know
much.
I've said this.
Thank you.
You're welcome.